So picture this. You've survived a stroke, and the absolute hardest days, those terrifying early weeks in the hospital surrounded by all those monitors and alarms, well, they're finally behind you.
Right. The worst is theoretically over.
Exactly. You've been putting in this grueling, just exhausting work in physical therapy, and you are finally ready to get back to your life. I mean, you want to go home, make your own coffee, maybe walk your own neighborhood.
Just normal everyday things.
Yeah, but every time you try to take a simple step, your own foot betrays you, like your toes drag. The front of your foot catches on the carpet,
Oh,
and
yeah.
suddenly you're gripping the wall, right?
Mm-hmm.
Reaching out in a panic for a piece of furniture, just terrified you're going to fall.
Mm.
And because of that ever-present fear, you end up altering your whole life.
You have to. You slow right down.
You do. You stop going to the grocery store alone. You skip walking to the park with your grandkids. That dragging foot, which is clinically known as foot drop, is quietly, step by step, just stealing away the independence you fought so hard to regain.
It really is. And that scenario is an incredibly common and, frankly, deeply frustrating reality. I mean, we are talking about 20 to 30% of all stroke survivors experiencing this specific impairment.
Wow, that many.
Yeah, up to 30%. It completely alters how a person interacts with the physical world, turning a simple trip to the kitchen into this, high-stakes obstacle course.
Well, today's deep dive is exploring a truly fascinating showdown in the world of rehabilitation surrounding that exact obstacle. We've got a great stack of research in front of us today.
We really do.
It's anchored by a 2016 meta-analysis from the Journal of Rehabilitation Medicine. That was by researchers Prenton, Hollins, and Kenny. And we're also looking at this highly relatable clinical blog post that sort of grounds the science in the everyday patient experience.
Right. And the setup for this analysis is just compelling because it presents this classic battle of, old versus new.
Definitely. We're comparing the traditional, purely mechanical fix for foot drop against this futuristic high-tech solution.
And what elevates this beyond a simple product review is that the medical community made a massive, logically sound assumption about which of these interventions would win out over the long term.
Based on how the brain heals. Right.
Exactly, based on everything we know about neuroplasticity and recovery.
Well, spoiler alert, the final results completely upended those clinical expectations. But to understand the twist, we first have to understand the mechanical failure that's happening in the body. So what exactly is going wrong when someone experiences foot drop after a stroke?
So the simplest way to describe foot drop is the inability to dorsiflex the foot.
Okay, let's unpack this. Dorsiflexion.
Right. Dorsiflexion is just the medical term for lifting your toes and the front of your foot upward toward your shin. So during a normal walking stride, there's a swing phase.
That's the moment your leg is moving forward through the air.
Exactly. You naturally dorsiflex your foot so your toes clear the ground, allowing your heel to strike the ground first.
Which is an automatic reflex most of us never even think about.
Until the exact moment you suddenly can't do it. After a stroke or other traumatic brain injuries, there is damage to what we call the upper motor neuronal pathways. You can kind of think of the central nervous system like a massive telecommunications network.
Okay, I like that analogy.
The brain is the control center, right? And it's trying to send a signal down the spinal cord to the dorsiflexor muscles in the lower leg, basically telling them to lift the foot.
But the stroke has, effectively frayed or severed that specific phone line?
Exactly. The signal just never arrives. And sometimes this is compounded by overactivity or spasticity in the calf muscles, which physically pulls the foot down even more.
Making it even worse.
Yeah. The result is the foot simply drops, acting like an anchor. It makes walking incredibly inefficient, it requires massive amounts of extra energy, and it drastically increases the risk of a catastrophic fall.
So for decades, the standard medical answer to that severed phone line has been a purely structural intervention, right?
Yeah.
The ankle foot orthosis, or AFO.
Yep, the AFO.
If you have ever seen someone wearing a molded plastic brace that goes down the back of their calf and sort of slips under their heel inside their shoe, that is an AFO. I mean, imagine walking around in a very stiff, slightly heavy ski boot all day.
That's a really good way to picture it.
It solves the immediate problem of tripping by physically locking your foot at a rigid 90-degree angle. So your toes physically cannot drop.
But from a clinical perspective, that rigid locking mechanism is exactly why AFOs have faced such heavy criticism over the years.
Because it's too restrictive.
Yeah, I mean, they do provide an immediate orthotic effect, meaning the moment you put it on, the tripping stops. But rehabilitation is about long-term recovery. The pervasive concern has always been that relying on a rigid piece of plastic has detrimental effects on the adaptability of your walking over months and years.
Well, because your ankle is locked, it can't naturally roll.
Right. And you lose neuromuscular control.
Yeah.
The body is highly efficient, you know. If a piece of plastic is doing all the physical work of holding the foot up, the body just stops sending resources to those leg muscles.
Oh, wow. So they atrophy.
Exactly. They atrophy. The muscle biomechanics fundamentally change just because of the brace.
And beyond the biomechanics, there's the massive human element here. I mean, the sources point out that patients generally despise wearing them.
They really do. They are hot, restrictive, and aesthetically just bulky.
Yeah, think about the very real human vanity of trying to squeeze a thick plastic orthosis into dress shoes for a daughter's wedding.
Or dealing with a sweaty plastic cuff in the middle of summer.
Ugh, yeah. It's uncomfortable and it's glaringly obvious.
Which heavily impacts patient compliance. And the most brilliant medical device in the world is completely useless if it spends 6 days a week sitting in the back of a closet.
Right, because the patient feels self-conscious or physically uncomfortable wearing it.
Exactly.
So if the problem with the plastic brace is that it makes the leg lazy and shrinks the muscle, bioengineers must have realized they needed something that actually forces the muscle to do the work.
Enter the challenger.
Yes, that brings us to functional electrical stimulation, or FES. This is where we get into the sci-fi territory.
It really is sci-fi.
Instead of strapping a piece of rigid plastic to your leg, FES uses a small device, typically like a lightweight cuff worn just below the knee.
Right.
And it delivers gentle electrical pulses directly to the common peroneal nerve, the specific nerve that controls the muscles responsible for lifting the foot.
It is a brilliantly elegant application of bioengineering. The device uses these advanced tilt sensors or foot switches to detect the exact millisecond your leg enters the swing phase of walking.
Oh, so it knows when you're stepping.
Yes, and at that precise moment, it delivers the electrical pulse, the muscle contracts, and the foot lifts completely naturally. It essentially replaces the lost brain signal with a localized external electrical signal perfectly timed to the person's unique gait cycle.
Okay, but let me push back on this approach for a second. If this device is just externally zapping the nerve to make the muscle twitch, isn't that essentially treating the patient's leg like a marionette puppet?
That's a common question, yeah. Like, you are just pulling the physical strings with electricity. How is a localized leg zap actually helping the brain recover from the neurological damage of the stroke?
Well, what's fascinating here is the underlying theory of neuroplasticity. That's what makes this so compelling. And it is why the medical community hypothesized FES would absolutely dominate the old plastic braces.
Because it's doing more than just lifting the foot.
Exactly. They didn't view it as just a marionette string. They believed FES was actively rewiring the brain through a concept called Hebbian learning. The foundational rule of neuroscience is basically neurons that fire together, wire together.
Okay, I need an explanation of how a zap on the calf wires anything up in the brain.
Okay, so when a stroke survivor wearing an FES device tries to take a step, they are generating a voluntary, conscious motor command from their brain, right?
Right, they're thinking, take a step.
Yeah, and sending that signal down that damaged spinal pathway.
Yeah.
Well, at the exact same fraction of a second, the FES device sends an electrical pulse into the peripheral nerve in the leg.
Some of that electrical signal travels down to the muscle to lift the foot, obviously, but a portion of it, which is called an antidromic action potential, actually travels backwards up the sensory nerve toward the spinal cord.
Wait, really? So we have the brain's voluntary signal traveling down the damaged pathway and the artificial electrical signal traveling backwards up the nerve.
You've got it. Think of the damaged neural pathway like a washed-out bridge over a river.
Oh, that's a great image.
The brain is trying to build the bridge from one side through voluntary effort, and the FES device is sending construction materials from the opposite side.
And they meet in the middle.
Exactly. Where those two signals meet in the central nervous system at the segmental level of the spinal cord, they lay down new pavement. That perfectly timed collision of voluntary effort and external electrical stimulation forces those specific synapses to activate simultaneously.
Oh, wow. So they fire together and wire together.
Right. Researchers believed this simultaneous firing would actually help the nervous system repair and strengthen its damaged neural pathways over weeks and months of use.
And because the AFO was just a static piece of plastic and FES was theoretically driving this active neural repair, FES was crowned the undisputed heir apparent for long-term rehab.
Without a doubt, it was the assumed winner.
Which brings us to the actual showdown. Sarah Prenton and her team at the University of Huddersfield decided to rigorously test this massive clinical assumption.
Which was so necessary.
Yeah, their 2016 meta-analysis gathered every high-quality, randomized controlled trial like the absolute gold standard of medical research that directly compared AFOs to FES for foot drop caused by central neurological issues like strokes.
And it was a solid sample size, too.
It was. They combined 5 robust trials tracking 815 stroke participants.
And the strength of this meta-analysis really lies in the specific metrics the researchers chose to evaluate. For a long time, clinical research was obsessed with abstract laboratory data.
Like what?
Like putting a patient on a treadmill, hooking up a bunch of electrodes, and measuring, say, a 5% increase in isolated muscle voltage.
Right, which sounds great on paper.
But a 5% voltage increase means absolutely nothing to a patient if they still cannot walk to the bathroom safely in the middle of the night. So Prenton's team focused on activity and participation domains.
Real-world stuff.
Exactly. They looked at the 10-meter walk test, which measures pure functional walking speed. They looked at functional exercise capacity, which just tracks how far someone can walk in a set amount of time.
They also utilized the timed up and go test, right? Which measures how quickly someone can stand from a chair, walk a short distance, turn around, and sit back down.
Right, which is basically simulating the exact movement of getting up from the dinner table to go answer the front door.
Yeah. And they also measured perceived mobility using the stroke impact scale, asking the patients how mobile and confident they actually felt in their daily environments, not just in some sterile clinical lab.
The patient's actual experience.
So the stakes are perfectly set. On one side, the clunky, rigid plastic brace that just physically blocks the foot from dropping and historically causes muscle atrophy. And on the other side, the high-tech, brain-rewiring electrical stimulator building that washed-out bridge. Which one helps stroke survivors walk faster, further, and with more confidence after weeks or months of continuous use?
Based on everything we just discussed regarding neuroplasticity, the entire rehabilitation community expected the FES device to show vastly superior long-term results.
Well, here's where it gets really interesting. When Prenton and her team ran the numbers on all 815 participants across these studies, FES was not statistically superior.
Nope, not at all.
Across the board walking speed, functional capacity, mobility, real-world confidence, both the ankle-foot orthosis and the functional electrical stimulation produced comparable positive improvements.
It was a dead heat, a complete statistical tie.
I am genuinely shocked by that outcome. I mean, how can decades of complex clinical assumptions about antidromic action potentials and neural bridge building tie with a piece of plastic you just slip into your shoe?
It's wild, isn't it?
Did the researchers get the FES technology wrong? Did it simply fail to work?
Oh no, FES worked beautifully. Both interventions resulted in significant, life-altering improvements for the stroke survivors. The mystery wasn't why FES failed. The mystery was why the basic AFO succeeded to the exact same degree over the long term.
Right, completely defying all those fears about muscle atrophy and biomechanical limitation.
Exactly. So to synthesize this phenomenon, we have to look really closely at one of the underlying trials included in the meta-analysis. This one was conducted by a researcher named Kluting and colleagues.
Because Prenton's meta-analysis did note a lack of specific physiological data across the board, right? Like, they didn't have widespread electromyography tests to definitively prove if the calf muscles themselves were getting stronger.
Right, they were missing some of that granular muscle data. But Kluting's study brought a completely different puzzle piece to the table.
And what was that?
Kluting's team utilized continuous activity monitors, specifically this specialized ankle device called a stepwatch, to track what the patients were actually doing when they left the physical therapy clinic and lived their normal lives.
Spying on their steps, basically.
Basically. And that data provided a glaring clue to the mystery. They found that patients in both the AFO group and the FES group took significantly more steps per day as the weeks went on.
Wow.
We're talking about a jump from around 1,800 steps a day at the beginning of the trial to over 2,300 steps a day by week 30.
That is an extra 500 steps every single day.
It's huge.
Over a week. That's 3,500 extra steps.
Yeah.
When you think about the psychological toll we discussed earlier, the fear of tripping, the reluctance to go to the grocery store, an extra 500 steps means they're getting their mail again.
Exactly.
They're walking around the kitchen instead of asking a spouse to fetch a glass of water. It just represents a massive return of confidence.
Which brings us to the fundamental truth of neurological rehabilitation. The single most critical factor for the recovery of motor impairment isn't necessarily the specific technology applied to the limb.
What is it then?
It is the intensity of task-specific repetition. To get better at walking, the brain requires the patient to do a massive amount of walking.
Right. Because both of these devices, regardless of their mechanical or electrical differences, successfully removed the immediate fear of catching a toe and falling over, so the patients finally felt safe.
Yes, the technology gave them the psychological permission to move.
And because they felt safe, they simply walked more, putting in thousands of extra repetitions.
The researchers concluded that the comparable long-term improvements were not necessarily about the specific mechanism of the device itself. Instead, both devices acted as a catalyst for repetition.
That makes so much sense.
Right. They both provided that vital, immediate orthotic effect, holding the foot up, which allowed the patient to safely engage in the heavy, repetitive practice required to drive overall functional recovery.
So what does this all mean? If you're a stroke survivor listening to this, or you're caring for a loved one dealing with foot drop, hearing that an expensive high-tech FES device just tied with a standard plastic brace might initially sound like a disappointment.
Yeah, it sounds like the sci-fi future hasn't arrived yet.
Right. But when you look at it from the patient perspective, this clinical tie is actually a massive real-world victory.
It is the ultimate victory of choice and validation for the patient.
Exactly. If you hate the bulky, restrictive feeling of an AFO, if you hate that you can't wear normal shoes or that it locks your ankle in this unnatural position, well, this data proves that functional electrical stimulation is a completely valid alternative.
It's not just experimental, unproven gadgetry. It is a scientifically validated, peer-reviewed option that works just as well.
So you can advocate for FES to get a more natural step where your ankle actually rolls and moves the way the human body was designed to move.
And the invisible hurdle in all of medicine is patient compliance. The best clinical intervention on earth fails if it doesn't fit into the patient's lifestyle.
Very true.
Some patients strongly prefer the sensation of FES because it physically activates their own muscles and just feels less restrictive.
But on the flip side, if you're someone who prefers the low-tech, rugged simplicity of a brace-like, you don't want to worry about charging lithium-ion batteries.
Or placing sticky electrodes precisely over a nerve every single morning.
Or dealing with skin irritation from the adhesive. If you don't want to deal with any of that, you can stick with your AFO. You can do so knowing definitively, backed by meta-analytical data, that you are not sacrificing your long-term walking recovery.
Exactly. You aren't settling for a second-best treatment. You are getting an equal therapeutic benefit with the tool that fits your daily life.
That's incredibly reassuring.
It is. Now, we do need to maintain clinical rigor here and acknowledge the caveats the researchers themselves highlighted. The vast majority of the participants across these 5 trials were chronic stroke patients.
Meaning they were pretty far along in their recovery journey.
Yes. This means they were many months, or in some cases almost 7 years, past their initial stroke.
Wow. Okay, so their neural pathways had been in that damaged state for a very long time.
Right. There is still a vital need for large-scale research into subacute patients, people who are in those first few critical weeks or months post-stroke, where the brain's neuroplasticity is highly active and malleable.
That would be really interesting to see if FES has an edge there.
It would. We also still need those detailed physiological studies we mentioned earlier to measure the underlying mechanisms. We need to know if the muscles themselves are actually hypertrophying, meaning are the muscle fibers actually growing thicker and stronger over time with FES compared to the AFO?
Right, but from a purely functional day-to-day standpoint of how fast you walk, how far you walk, and how confident you feel, the results are remarkably clear.
Very clear.
It is an incredibly empowering realization. We started this deep dive exploring how the fear and physical frustration of foot drop literally shrinks a person's world, keeping them confined to a chair.
Yeah, stealing their independence.
But what this rigorous battle between a molded piece of plastic and a sci-fi electrical nerve stimulator ultimately proved is that simply removing the barrier to movement is the most important step of the entire recovery journey. It doesn't necessarily matter if you use a rigid brace to physically hold the foot up or targeted electricity to make the muscle pull the foot up. What matters is that the intervention makes you feel safe enough to get off the couch, walk out the front door, and take those extra 500 steps a day.
And that realization leaves us with an important, almost philosophical question to consider.
Oh, lay it on me.
Well, in our modern medical landscape, we are constantly chasing the most advanced, complex technology to cure our ailments. We constantly want the magic pill, the brain rewiring electrical pulse, the effortless external fix.
Naturally, we want the easy way.
Right. But what if this meta-analysis reveals that the ultimate rehabilitation tool isn't a specific piece of gadgetry at all?
Okay.
What if the true medicine is simply our own human willingness to put in the grueling repetitions once the mechanical barrier is removed? If a simple plastic brace and an advanced neural stimulator both just serve to get you back on your feet, maybe the real miracle cure isn't the technology you strap to your leg. Maybe the real miracle cure is just the walking itself.
That is profound. The technology is simply the key that unlocks the door, but the patient still has to be the one to actually walk through it.
Exactly.
So the next time you see an advanced piece of medical hardware or read about some futuristic rehabilitation breakthrough, remember that the human body and the sheer, stubborn willpower of repetition is sometimes the most advanced technology we have.
The muddy waters of clinical research often reveal that there are multiple equally valid paths to the exact same destination of recovery.
Which is exactly why we do these deep dives into the data. We want to look past the historical assumptions and find out what actually gets you moving forward.